Welcome back to the Masterclass. Today, we're diving into a punchy, zero-fluff explainer on the CMS ICD-10 CM Section 4 guidelines. We're talking outpatient surgery, observation, and emergency encounters. If you've been with us for the Decode Healthcare with Harshal series, you know we're systematically breaking down every single rule to keep your claims perfectly compliant and your reimbursement optimized. Today is all about those sudden, abrupt status shifts and exactly how your coding has to pivot instantly to match.
Here is the agenda for today's explainer. We've got our welcome to Part 92, then we'll hit surgery and pathology shifts, observation and inpatient conversions, ED workups, and canceled surgery, and finally our masterclass wrap-up. Let's eliminate the guesswork.
Section 1. Welcome to Part 92, the Masterclass Mission.
We're jumping right into our scenario-based masterclass. The whole point of this explainer is to absolutely lock down compliant diagnosis sequencing when a patient's status turns on a dime. Now, in the outpatient world, we use the term first-listed diagnosis instead of the inpatient principal diagnosis, and figuring out that first-listed condition can get incredibly messy when a routine visit suddenly turns into an admission, or a planned surgery just totally derails. We all know the sheer panic of a chart changing right before you hit submit, right? So our mission today is to make sure you know exactly which rulebook you need at every single stage of the patient's journey.
Section 2. Surgery and pathology shifts, the ambulatory rule.
Let's start with our first scenario. A patient scheduled for ambulatory surgery. The official CMS mandate, specifically Section 4A1, is super clear here. It dictates that the condition prompting the surgery is always sequenced first. It's the primary reason for the encounter, period. And listen to this, because it's crucial. This applies even if the surgery ends up not being performed because of a contraindication. The reason they walk through the facility doors is your anchor. But there's a massive, frequently missed exception when laboratory pathology gets involved.
And this is where things get really interesting. This rule literally overrides your pre-operative assumption. According to Section 4N for ambulatory surgery, if you have the definitive post-operative pathology results in hand before you bill, and they differ from what you suspected pre-op, you absolutely must select the post-operative diagnosis. It takes complete precedence because it is the most definitive. You do not code the symptom, and you don't code the screening if you've already got that confirmed pathology report sitting right in front of you. This is a brilliant illustration of how a claim transforms. Imagine a patient comes in for a benign K63.5 colon polyp. But wait, literally right before you drop the claim, the lab report comes back and confirms a malignancy. That benign indication instantly shifts to a malignant primary diagnosis, C12.6. Your claim has to reflect the absolute highest degree of certainty available the exact moment you code it.
Moving right along to Section 3. Observation and inpatient conversions, shifting code sets.
Okay, let's transition out of the surgical suite and head over to observation. When a patient is placed in outpatient observation, we strictly follow Section 4 rules. You always list the prompting medical condition first. So say a patient is admitted to observation for severe chest pain, and maybe they have a history of COPD. You are sequencing that chest pain first because it's the specific reason they are in observation. We only ever use those specific Z observation codes like Z3 or Z4 for suspected conditions that end up getting completely ruled out. But what happens if things escalate?
Look at this progression. The exact second, and I mean the absolute second that formal inpatient admission order is signed by the doctor, we completely abandon the Section 4 outpatient rules. We toss them out. Instead, we switch over to Section 2 rules, applying the Uniform Hospital Discharge Dataset, or UHDDS. At that point, you're no longer looking for a first-listed diagnosis, you are hunting for the principal diagnosis, which is the condition established after study to be chiefly responsible for occasioning the admission. It's a fundamental, game-changing shift in how you read that medical record.
Section 4. ED workups and canceled surgery, strict sequencing.
Now we're in the fast-paced emergency department, where diagnoses often evolve in a matter of hours. The golden rule here is that the first listed diagnosis is the condition chiefly responsible for the evaluation. What does that mean? Well, if a patient comes in with an initial symptom like acute chest pain, but after a really thorough workup, the doctor establishes a definitive diagnosis of acute GERD, that confirmed definitive diagnosis replaces the initial symptom on your claim. You're coding the GERD, not the chest pain.
All right, time to test your masterclass knowledge. What is the rule if the ED physician actually cannot determine the exact cause of the problem before discharging the patient?
Remember, inpatient coding lets you code suspected or rule out conditions as if they actually exist, but outpatient rules, they are vastly different.
Hit the nail on the head. You fall back on the primary signs and symptoms. If the doctor writes down probable appendicitis and sends the patient home, there is no way you can code appendicitis. You have to ensure your coding strictly matches the confirmed documentation without guessing. So you code the abdominal pain, you code the fever, the nausea, whatever signs and symptoms were the chief reason for that ED evaluation.
Now let's talk about one of the most highly audited scenarios out there, the canceled surgery. If a scheduled outpatient surgery gets canceled because of a complication, like, say, the patient develops a sudden, massive exacerbation of asthma right before their tonsillectomy, you have to force this very rigid three-tier sequence onto your claim. Step 1, the reason for the surgery is your first listed diagnosis. Step 2, you code the complicating condition, in this case, the asthma. And Step 3, you cap the whole shebang off with a Category Z53 cancellation code. That tells the payer exactly why the procedure wasn't carried out. It is a perfect, compliant three-part story.
Finally, Section 5, Masterclass Wrap-Up, Looking Ahead.
We have covered a massive amount of technical ground in this explainer today. From definitive lab results completely overriding pre-op suspicions, to the exact moment an observation patient flips to inpatient rules, all the way to those super strict Z53 cancellations. It all boils down to coding the absolute highest degree of certainty based strictly on the documentation at the time of the encounter. Make sure to like and subscribe, because in Part 93 we are tackling the massive coding differences between facility claims on the UB04 and professional claims on the CMS 1500. It's a wildly different landscape. So I want to leave you with this. Is your modifier usage truly compliant across both settings, or are you accidentally leaving revenue on the table while exposing your practice to a massive audit? Think about that, and I'll see you in the next explainer.